Thank you. With that, seeing no other questions, we move on to the next person on our list, Mr. Lou Rinaldi. Mr. Rinaldi, you're on.
Good afternoon, members of the Public Health Committee. My name is Lou Rinaldi. As the originator of Connecticut Public Act number 2379, Section 49, which established the nation's first office of the Cannabis Ombudsman, I speak to you today rooted in a deep commitment to patient advocacy and rational, evidence-based health policy. I'm here to offer conditional support for Raised Bill 5242. This legislation promises compassionate end-of-life care by allowing terminally ill patients to access medical cannabis within healthcare and hospice facilities. However, to turn this promise into a reality, we must directly address the opposition from the Connecticut Hospital Association and the Connecticut Association of Healthcare Facilities, while simultaneously fixing burdensome patient restrictions within the bill's current language. I see we've got almost all the co-sponsors on this call right now, and I'd like to thank you for your work on this bill before I proceed. To our colleagues at the CHA and the CAHCF, I validate your concern. Protecting your DEA registrations and CMS funding is paramount to keeping your doors open. However, opposition based on federal illegality ignores the ironclad structural safeguards already present in this bill. The no-touch chain of custody, for example, this bill does not force your pharmacists or nurses to procure, dispense, or handle a Schedule I substance. The language clearly places the responsibility of storage and use on the qualifying patient. By shifting the administration entirely to the patient, your clinical staff and your DEA registrations remain insulated. There's also a built-in exit ramp. If you fear a sudden shift in federal enforcement, I direct your attention to Section 1D, that's 1 Delta. This provision explicitly allows a facility to suspend compliance if a federal agency issues a rule or notification prohibiting cannabis use. You are not permanently trapped by a state mandate. The bill legally protects your right to suspend the program instantly if your federal funding is ever genuinely threatened. The reality of precedent should also be considered in states like California, which passed similar legislation known as Ryan's Law. Hospitals of all sizes comply without issue. To date, CMS has never revoked a hospital's funding, nor has the DEA revoked a facility's registration for allowing a terminally ill patient to self-administer state legal medical cannabis. While we must protect our facilities, we cannot do so at the expense of the patients this bill is meant to serve. As currently drafted, several restrictions undermine compassionate care. I'll start with the blanket ban on inhalation. Section 1 explicitly prohibits both smoking and vaping. Banning all inhalation removes the fastest and most effective route of administration for patients suffering from breakthrough pain, respiratory distress, and severe nausea. While combustion is entirely inappropriate in a clinical setting, dry herb vaporization must be explicitly permitted. Unlike liquid vapes or traditional smoking, dry herb vaporizers gently heat raw cannabis flower below the point of combustion. This provides rapid symptom relief without producing smoke, ash, or tar, making it safe and suitable for a controlled healthcare environment.
Mr. Rinaldi?
Yes.
And I should let everyone know, I get to be the voice today because Kathleen is having technical issues. So that's your 3 minutes. If you can summarize, that would be great.
Sure. There's also some restrictions on lock boxes that are somewhat subjective, and there's an emergency care ambiguity. I'm happy to talk about those offline. In conclusion, we have an opportunity here to lead the nation in compassionate end-of-life care, vastly improving palliative outcomes and honoring patient dignity in their final days. I urge the committee to amend this bill to explicitly permit dry herb vaporization, remove the locked container mandate, and clarify the transition from emergency care. To the CHA and the CAHCF, I urge you to look closely at the fail-safes provided in this text and stand with us in supporting these suffering patients. Thank you for your time, and I'm happy to take any questions now.
Thank you for your testimony. I will have Representative Claridis Dietra. She actually is one of the champions of the bill to start the conversation, and we'll have more opportunity.
Of course.
Thank you,
Hello,
Mr.
Representative.
Hello, Mr. Rinaldi. Thank you so much for being here. And I want to thank you for coming in and explaining, a lot of this to people so they have a better understanding. Couple of my questions are, besides California, what other states have passed this Ryan's Law?
So Ryan's Law is unique to California. I would have to do some additional research into other implementations in conjunction with our cannabis ombudsman, who I believe is in attendance of this hearing right now. But I can certainly follow up with you offline on that.
Okay, thank you. And then the follow-up to that, you talked about the issue with storage. What's the recommendation of how each individual patient would store and, have their medical cannabis on their person?
So, as you know, the bill allows facilities to reasonably restrict storage, including requiring a locked container. So, in a lot of these cases, these patients who are terminally ill are not necessarily able to manipulate locking mechanisms depending on the type of lock. There are, keys and combination codes that can be agonizing and an unnecessary physical hurdle for the patient. And also, if we're not clearly defining what reasonably restrict means, a hostile facility could implement consumption rules that were so narrow that they effectively block access altogether. So I guess it's a little bit more granularity in terms of how we are attempting to prevent these items from getting into the wrong hands. Although within a facility such as that, I wonder about the true risk. But we also need to take in mind the physical disabilities that may be impacting some of these patients. And if I may, I did just get a note from our cannabis ombudsman who says that there are 13 other states who have enacted laws similar to Ryan's Law. And she asks that you refer to her written testimony. That's Erin Gorman Kirk in the Connecticut office of the Cannabis Ombudsman. She's pointing out that there are 13 other jurisdictions in which this has already been enacted.
And you said Erin Gorman?
Erin Gorman Kirk, yes.
Okay. And then, that reminded me of something else. Oh, and CHA, and their concern, and rightfully so, is losing federal funding.
Yes.
If you could get us, so obviously none of these other 13 states have had an issue with their federal funding being revoked. So I think that's important for people to know and I understand, and they should be concerned, and they want to make sure that everything is written in such a way
Absolutely.
that they're not going to, risk losing any of the funding, because hospitals need it. They need every penny they can get.
That's correct.
Well, thank you again for being here. Any information that you have, would be great to send it over to us.
Absolutely. I'll be following up with you via email. Thank you so much.
Thank you. Thank you, Mr. Chair.
Madam Co-Chair, Representative McCarthy-Bailey.
Thank you very much, Mr. Chair. And thanks to Rep. Claritas Detria for her being a champion on this issue. And Mr. Rinaldi, as I get to be the voice today, actually am interested to go back to your testimony. And if you could just very clearly again outline you have three specific recommendations. One, I heard you were talking at the end of your testimony about the inhalation ban and that's a problem. So to allow for dry herb vapor inhalation. The second is the removal of the locked container mandate for storage because of the problems you just outlined in conversation with Rep. Claritas Detria. And then the third, if you could remind me of that third.
Sure, yeah. And I'm happy to speak about any and all of those. But the third is the emergency care ambiguity. The bill explicitly forbids cannabis use while a patient is receiving emergency care. And this is really more about the granularity in the statutory definition. Without a strict legal definition of when emergency care ends and stable inpatient care begins, a patient could be stalled in an administrative gray area, unnecessarily delaying their right to their medicine. So I don't necessarily think we need to remove provisions around lockboxes and definitions of emergency care. I think it's just a drafting revision to maybe as Representative Claritas Detria said, look at some of those other jurisdictions where this has already been implemented successfully, and maybe look at the language that was used in those scenarios to try to solve for those two issues that I highlighted. And regarding the inhalation, that is also correct. nobody wants to see, combustion happening in a clinical environment. I think we all understand that there's a number of problems and concerns with that. The technology behind the dry herb vaporization, there's actually a company based in Germany called Storz and Bickel that produces medical cannabis vaporization devices explicitly for use by medical patients, particularly in palliative care scenarios. So there's precedent there, and there's ways that we can look at allowing the inhalation and the immediate onset effect that it brings without having thick clouds of smoke drifting through a healthcare facility, which we all agree is in nobody's best interest. I hope that answers your question.
Absolutely. That's very helpful. I would also ask that if you're sharing information, if you would kindly send it to Beverly Henry, that way the entire committee will be sure to have access to it, because I think it will be helpful as we move forward in this conversation.
Happy to do so, Representative. Thank you.
Thank you for being here today. Thank you, Mr. Chair.
Thank you, Rep. Mara.
Thank you, Mr. Chair. Okay, so I'm looking through the bill, but I also kind of checked through the ombudsman report, and this all kind of makes sense to me. The only part that I have a problem with is, and I know this is not in the bill, but is the dry herb vaporization. Well, I realize that there's less odor with something like that. It still does produce an odor, which I think is, I don't know if you have any comments on that. To me, that seems like it's one thing to make sure that someone is having that palliative effect, but if they're doing that at the risk of someone else around them having to now smell cannabis in the hospital setting, that seems like maybe a non-starter, but I don't know if you have any thoughts on that.
That's actually a really astute observation, and I commend you for drawing the distinction there. There is absolutely an odor associated, but it is, I would consider it orders of magnitude reduced from traditional combustion. I also think that we have a number of options in terms of active ventilation systems that can be utilized for this purpose. We see them implemented in healthcare facilities. We see them implemented in even in our casinos and other facilities where air quality is of paramount importance. I think that there is room to investigate, certainly, to look into options for permitting dry herb vaporization while not having it infringe upon the health and or well-being of any other patients or staff in the facility. I think it at the very least warrants an exploratory investigation to determine if this is something that we can make work, because the benefit of allowing this, again, in terms of the different routes of administration that are available, this is something that would have comparatively the fastest onset. When a patient takes an edible, for example, they could be waiting 45 minutes to an hour for relief to set in, and other mechanisms are also similarly time delayed. And it's of great importance that we're able to provide as quick relief as possible. So yes, you're absolutely correct, and I would like to lend my efforts, my time to assist with any sort of exploratory investigation in that regard. Thank you.
Okay, thank you. Thank you so much. I think like my concern, of course, is that if we mandate and say that you're going to have to allow this, and you're also going to have to allow vaporized, I'm okay looking at that kind of in the long term. If there is a facility that happens to have an area that has air quality that could be used for that, but I guess I'd be really concerned with the rising cost of healthcare cost, saying now your healthcare facility has to have another ventilation system. I mean, we probably need to focus on the best thing that we can do for people.
Right. And that's why I say exploring it is certainly valuable, because some facilities may already be equipped accordingly and some may not. I don't necessarily think we have to mandate it in the bill, I'm not, anything close to policy counsel, personally, but I think maybe if we can include it as at least an option in a revised draft to allow facilities on a case-by-case basis to determine if this is something that they are equipped to support or not. And then maybe at a future point in time, they elect that they would like to move in that direction. They certainly have it within the realm of possibility to do so. So, maybe not a strict requirement, but certainly maybe an exception to the blanket ban on inhalation on a case-by-case basis.
Right. Okay. Thank you so much.
Thank you.
Thank you. So I just wanted to ask a couple of questions. And first, I wanted to make a couple of comments. So when a person is in hospice or close to end-of-life care, there's a lot of anxiety. And the families that are around them, we use benzodiazepines quite a bit. And that would make a person very sleepy and take care of the anxiety too. But you may lose some moments with the loved ones when you're knocked out, so to speak. So this option is a very reasonable option where it would create some calmness, but not necessarily have the person be completely sedated. So that's why I'm one of the supporters and co-sponsors of this bill too. So I wanted to give the rationale that why is it worthwhile? Because for some families, it's going to be very relevant. It's an anxiety controlling medicine in that situation and without causing some of the side effects from some of the peer medications, if you will. The second part is the sublingual cannabis oil is available, which has a pretty fast onset of action. And we do not necessarily need to get into the inhaled dry version where the temperature is very high and you have oxygen in most of those patients. So you don't want to add more complexity to a situation where the hospitals are already struggling for other reasons. We should actually look at it. What can we do to take care of the patient's needs? And what can we do to be able to make sure that the people who are hesitant, give them comfort about this? The fact that 13 other states have been able to do this should give us a little bit of a comfort then that it's not as much of a federal issue. The federal laws are not changing. As we know, it takes a long time to change a federal law. They will come together and probably change some of the laws, but they're going to have a lot of inertia because they're dealing with interesting other issues. So therefore, I think it may be worthy to look at the lockbox part and some of the other components a little bit more. And this is just me speaking. Of course, we will all sit down and have conversations, but that's where I think maybe an opportunity. But your testimony is really helpful, and the testimony of many of the others is very helpful to us. Thank you.
And I'm grateful for your work on this bill. I think this is really a step in the right direction for a state that has, we've made cannabis legal, but we haven't necessarily done the work to counter some of the longstanding stigma associated with the plant. So I think this is a fantastic step in that direction in a way that is able to demonstrate, positive outcomes for patients. So thank you.
You had raised your hands earlier, Representative McCarthy. You good? Okay, seeing no other questions or comments, thank you for your testimony.
Thank you so much.